Hello friends, in the sequence of ENT lectures about rhinology, that is science of nasal cavity and its disorders, I am today presenting a unique topic. This is very interesting one, that is allergic fungal sinusitis. That is invasion of the paranasal sinuses by fungal element. My name is Dr. Atul Bhardwaj. Please subscribe my YouTube channel also in order to support the cause. Let me share the screen first. And today's topic, obviously, I've already shared with you is fungal sinusitis. And let me expand it first. In the previous class, we have already gone through this acute bacterial rhinosinusitis. That is a acute invasion of or inflammatory sequence of the paranasal sinuses. And in chronic rhinosinusitis, we have got two types of chronic rhinosinusitis. That is, number one is with polyp, and the second one is without polyp. Let me take a pen first. Okay, so actually, fungal sinusitis is a classification or a domain which is considered under chronic rhinosinusitis. Rhinosinusitis, or we will call it as a CRS now. So we have got ABRS, that is acute bacterial rhinosinusitis, which is supposed to be a bacterial infection or a inflammatory response of the nasal cavity and paranasal sinuses mucosa. And this chronic rhinosinusitis is if the inflammatory sequence exceeds the time limit of 4 weeks, and it is of two types, with polyp and without polyp. So chronic rhinosinusitis without polyp, is essentially a neutrophilic response, just like any bacterial response. Whereas chronic sinusitis with polyp is essentially like a allergic rhinitis disorder, which is a IgE mediated type 1 hypersensitivity reaction. So the presence of polyp in a sinusitis or a chronic rhinosinusitis essentially explains the possibility of, or elucidates or confirms the pathology has got a eosinophilic infiltration as well as IgE. Uh, uh, you can say IgE count is also enhanced in case of a polyp situation. Whereas in case of a without polyp situation, the chronic rhinosinusitis is just like a IL-6 or a IL-4 or a bacterial rhinosinusitis. So in the chronic rhinosinusitis, we also has a topic which is a fungal sinusitis, or rather called as a fungal rhinosinusitis, which is a fungal invasion of the paranasal sinus and the nasal cavity mucosa. So this is essentially a clinical identity characterized by the sinus mucosa, sinus in the sense is paranasal sinuses. We have got four groups. We have already discussed in various sections, four groups: frontal, ethmoidal, and sphenoidal, and ethmoidal. We have got these four groups of sinuses. Sinuses are nothing but the air-filled cavities, and they are the modified cavities in different bones, in four bones actually: the frontal bone, the maxillary bone. Ethmoid itself is a complex or a labyrinthine kind of a bone, which has got various air-filled cavities, and the sphenoid body. And the body of the sphenoid also has got an air-filled cavity, which is nothing but a sphenoid sinus. So the sinus are lined with the mucosa, uh, just like a respiratory epithelium, like which is pseudo-stratified ciliated columnar epithelium. The paranasal sinuses are also lined by the same mucosa as the nasal cavity. The reason behind that is purely embryological, because the paranasal sinuses are the extension of the nasal cavity, in speaking in a embryological terms. Embryological terms. So this allergic, this fungal sinusitis or fungal sinusitis is essentially or more commonly you can say is observed in immuno compromised patient in case of a invasive property is there. Invasive in the sense is if the fungal element or the fungal sinusitis or a fungal rhinosinusitis has got a property of invasion, bone destruction, bone expansion, tissue destruction, then it is this case is strongly observed in case of an immunocompromised person. Whereas a type 1 hypersensitivity reaction, just like an allergic reaction, is observed in immunocompetent person. So allergic fungal sinusitis is not limited only to immunocompromised person. It is also seen in immunocompetent person or patients rather. So different causative agents or different fungal elements, fungal colonies which are involved in the case of allergic fungal sinusitis is aspergillus, which is way more common, most common, in fact, way more common. By far, the most common is aspergillus or aspergillus. And the second one is mucormycosis. Candida is relatively less seen in case of a fungal sinusitis. So you can say by far the most common fungal sinusitis is because of the aspergillus fungal species. And when we this is the classification of allergic fungal sinusitis, very very important. When the fungus has got a property of invasion of the surrounding tissue invasion, surrounding invasion, bone destruction, and bone expansion, and encroachment also. Encroachments, and also there is a periarteritis also. Arteritis or the arteries which supplies the nasal cavity mucosa or nasal cavity mucosa and paranasal sinuses mucosa. This fungal element goes along these blood vessels of the mucosa and then spreads along the basement membrane. So because this rapidly expanding fungal pathology needs a vascularity, increased vascularity, which is provided by the arteries, and the fungal also shows the features of encroachment, or it enters into the blood vessels also, and overall the health of the nasal cavity and paranasal sinuses mucosa then becomes compromised or hypoxic, and even in later half of the disease or later part of the disease, you can have absolutely necrosed or blackish mucosa in case of advanced disease. So we have primarily we can say that we have got two types of fungal sinusitis. Number one is non-invasive in the senses there is no evidence in the senses of CT or a CT scan or a MRI, but the majority of the paranasal sinuses and its disorders in form of, as far as radiology is concerned, CT scan is by far the most common modality which is used for paranasal sinuses and its surrounding structures. But if you are having some kind of suspicion about brain parenchyma encroachment, the brain encroachment, and then obviously then MRI will be a supplementary or will have a superior resolution, and it will demonstrate a much better picture about the encroachment if the proper encroachment of the subdural space and brain parenchyma is concerned. But as far as the bone destruction and the surrounding bone destruction is concerned, CT scan or a CT paranasal sinuses in different sections like axial, coronal, and sagittal section, a small section is far more superior, but because it clearly delineates all the important structures like gula, ethmoidal, skull base, and cribriform plate uh, uh, much better than the case of MRI. So CT or a CT scan PNS is a commonly done uh, you can say a diagnostic radiology module along with nasal endoscopy. Nasal endoscopy. So apart from doing a comprehensive or um, a good endoscopy, you can also take some assistance in the form of a CT scan PNS in order to clearly uh, 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 delineate or determine what kind of a pathology is there, what kind of obliteration of the sinuses it has done, what kind of bone destruction it has done, and the surrounding structures is also well delineated in case of a CT scan. So the non-invasive variety is is nominated in the sense of that because the chances of bone destruction of the surrounding structures are relatively less encountered or not encountered in case of a non-invasive, whereas the invasive fungal is obviously a more, you can say, has got a more lethal property or a more virulent in nature, and the non-invasive is a innocuous or a rather friendly presentation of a fungal sinusitis. So again, this non-invasive is again ramified into two categories. The first one is allergic fungal rhinosinusitis. This is a allergic response against the fungal element, just like a IgE level or a type 1 hypersensitivity reaction against the fungal element. So this is a unique disorder which has got a allergic response like a atopic response in case of a urticaria or allergic bronchial asthma or allergic rhinitis. This is a atopy type 1 allergic response against the fungal element, the nasal cavity and the paranasal sinuses. Mycetoma will discuss later on, and the invasive is again of two types, acute invasive and a chronic invasive. First, we will discuss about the invasive type of fungal sinusitis. So, this is a chronic invasive fungal sinusitis, and obviously, the invasive type of fungal sinusitis is way more common in immunocompromised patients. So, immunocompromised patients compromised, like a poorly controlled diabetic or patients who are having some steroids for a long period of time in order to have some autoimmune response suppression, or even in a case of an organ transplant or a poorly controlled diabetic patient or arterial disease or various other factors which leads to immunocompromised state. So this invasive kind of a fungal sinusitis is way more common encountered in the case of a immunocompromised person. So the chances of bone destruction and this the kind of pathology, this invasive one has got a recurrent nature also. So the aggressive treatment and aggressive surgical approach is mandatory in order to manage the disease. Otherwise, the fatality rate is quite high in case of especially if the fungal sinusitis encroaches the brain parenchyma, or also there may be this posterior compartment of the orbital cavity. Then there can be orbital apex syndrome, and even the fungal can encroach. Actually, two type of encroachments of the advanced disease you can encounter. Number one is encroachment of the brain matrix or central nervous system, you can say, and the second encroachment are encroachment of the orbital cavity, in which the patient may lose his vision because of the invasion of the orbital cavity. He can have a post or pre-septal cellulitis or a frank abscess of the posterior compartment, and even a panophthalmitis and endophthalmitis may be there, but the patient can lose his vision also. So this is a CT scan you can see, and you can easily see that the patient has got a filled uh, maxillary sinus, and there is a destruction of the medial wall of the maxillary sinus, you can see, and the fungal element is also entered into the nasal cavity. So you can this is supposed to be the nasopharynx, and this is posterior nasopharyngeal wall, and this is foena, and this is posterior part of the septum. So this is nothing but this is the mandible, this condyle of the mandible, and these are pterygoid muscle. These are pterygoid muscle. This is the pterygopalatine fossa, and this is the nothing but infratemporal fossa. Infratemporal fossa. These are mastoid air cells, and this is pinna. So in this case, this is supposed to be the septum. The Fungal element has destroyed the medial wall of the maxillary sinus and entered into nasal cavity. So this unique attribution of destruction, particularly of the bones, because of very of you can say compromised blood supply as a result of compressing nature of the disease, the patient can have dead and decayed necrotic bones as well as a long-standing pathology. So treatment in case of a invasive disorder is quite a aggressive one. The patient has to be debrided or the dead decayed mucosa along with the the, the non recoverable mucosa has to be sacrificed, or endoscopic cleaning of the nasal cavity and the paranasal sinuses, apart from doing a full house endoscopic surgery in order to make the paranasal sinuses and the nasal cavity a single cavity. You have to do a complete FES or a functional endoscopic sinus surgery first in order to so that the nasal cavity and the paranasal sinuses can be made a single cavity which can breathe. Because if the patient is having multiple polypoidal like situation, then there is a are a chances of hypoxic environment in the nasal cavity also, and the patient has a blocked nasal cavity. So you have to do a full house test, and you have to sacrifice all the cavities or the bony spicules which are leading to this kind of a situation, and the surgery is called as functional endoscopic sinus surgery or endoscopic sinus surgery. And then the patient has to go for a aggressive surgical debridement in the form of a full house test, and then also amphotericin B, also voriconazole, which is a voriconazole, which is an antifungal agent and available in the form of IV, intravenous supplement, or not supplement, IV medication. IV medication is available, and the patient should be encountered aggressively with IV voriconazole as well as amphotericin B. And these patients requires a long-term follow-up in the senses, long-term debridement and douching. Douching is like a washing of the nasal cavity with saline, with the antifungal agents also. The patient even in some cases require a lifelong uh, follow-up. Just the second category of uh, this invasive fungal sinusitis is a more lethal form, or the mortality rate are quite high in case of acute fulminant fungal sinusitis, and the fungal element or the fungal mycelium or colonies are very very aggressive in these immunocompromised diabetic patients, or in a AIDS patient obviously, and they will encroach or they will enter by virtue of destruction of the bone. They will gain an entry into the orbital cavity or intracranial cavity, or even in the surrounding structures of the maxillary sinus also. But these two are primarily more having a possibly poor outcome, especially in case of intracranial extension. The patient can have a meningitis in or a subdural abscess, or even a brain abscess in case of intracranial extension, and the patient can the chances of survival are uh, also goes down in case of a fulminant fungal sinusitis which has got encroached into the intracranial part of the CNS. The second class is when the fungal element enters into the or gain access into the orbital cavity by destruction of lamina peparisea. You are well aware of the fact that it's supposed to be the nasal cavity of the orbital cavity, and this is supposed to be the nasal cavity. The thin part of the bone which is present between the nasal cavity and the orbital cavity is called as lamina peparisea, and this aggressive fungal hyphae or colonies gain access into the orbital cavity and cause a virulent cellulitis, which cellulitis, preseptal or postseptal cellulitis, which can even lead to a frank abscess of of the orbital cavity, and the patient may lose the vision completely, or goes blind, you can say. and this fungal element has got a propensity. Propensity word is used. Propensity in the sense is has got a predilection. Predilection is as a biased behavior, a favorite behavior against the blood vessel. So they grows along the blood vessel, and it's very virulent in the sense is very aggressive, and it can virtually kill the patient in weeks. And the patient can have features of meningitis as well. So meningitis as well as orbital apex syndrome, apart from uh, encroachment of the cavernous sinus, can lead to loss of vision also, and grave consequences as well in the form of death even in majority of the cases if the patient is not encountered in an aggressive manner, in the sense it dealt with aggressive debridement and endoscopic clearance with a chest surgery, apart from with antifungal agents, which I've already discussed, are also given specially intravenously in the form of voriconazole. So these patients usually present with orbital pathologies and proptosis, etc., and a PUO. What is PUO? Pyroxia of unknown origin. So these patients remain febrile even having best of the antibiotics, and because of a high amount of fungal load. And this is an endoscopic picture. We'll discuss this. So the treatment is emergency surgery in the form of endoscopic sinus surgery, which is aimed at making a large nasal cavity and removing all the bone pieces and the bone spicules of the partition of the paranasal sinuses, especially of the ethmoid region, is done, and then a complete FES surgery is performed, and aggressive douching of the nasal cavity with antifungal agents are also started. A radical debridement, even you have to sacrifice some part of the bone also in order to make the area accessible to the instrumentation and to the douching as well. Douching is nothing but you have you can say wash the nasal cavity with a copious uh, uh, saline plus normal saline plus antifungal agent, and this has to be continued unfortunately for even lifetime on it in order to make the cavity free from a recurrent fungal disorder. So obviously it has got a grave or a poor prognosis, because the encroachment sometimes even up to the deep structure of the brain parenchyma are there, and the patient goes into loss of consciousness, and even unresectable disease will obviously lead into a poor prognosis, and you can say death even. So this is a typical presentation of a orbital extension of the of the fungal element. The fungal element through the lamina papyracea has entered into the orbital cavity, and this can even lead to the thrombosis of the cavernous sinus, and this patient has got a cavernous sinus thrombosis. Cavernous sinus is the sinus which is uh, just superior to the sphenoid sinus, and it has got sixth nerve and internal carotid artery passing through. So cavernous sinus is a dural sinus, just like a superior sagittal or inferior sagittal sinus, or a superior petrosal, inferior petrosal sinus, and transverse sinus, all and this cavernous sinus all drains into a sigmoid sinus, which continues in the neck as a internal jugular vein. So this cavernous sinus is a confluence of different sinuses, and the thrombosis is a blockage by a thrombus, which is an aggregation of a platelets, leads to retrograde this preseptal edema of the leads in this case. And this is a non-invasive kind of fungal sinusitis, in which the patient is having, in fact, like a fungal ball is having, and surrounding tissue is hyperemic, but there is no destruction, no encroachment or destruction of the bone is there, because it's a non-invasive fungal sinusitis. So this is a mycetoma. Mycetoma is like a fungal ball. Mycetoma is a fungal ball, and it remains in the, particularly in the maxillary sinus, in an indolent and a harmless manner, and in many patients, it is diagnosed serendipitously in a CT scan, but this is not a much this disorder that does not cause much of a clinical picture, and the patient in various patients also the disease may present as in a silent manner, and the bone invasion and bone destruction property is absolutely absent in these cases because it's a non-invasive kind of fungal sinusitis. So you can say absolutely the bone is intact, uh, surrounding bone is absolutely intact, but it is filled with fungal element, and in between, so we have got a salt and pepper appearance, or you can say in a CT scan we have got a dual shadow, in which the white part is a thick inspissated or dried mucin is there, and surrounding we have got relatively blackish kind of a shadow, which is nothing but a loose fungal tissue. Fungal tissue is there, fungal disease is there with a mucosal edema or a secretions are there, but this whitish is a more dried kind of a radio opaque disease is there. So we have got two types of shadow in a single patient, or in a fungal patient, which is a radiologically very important in order to exclude or differentially diagnosis this patient from a chronic rhinosinusitis, which is neutrophilic in many cases. So this dual shadow, or the presence of a two types of shadow in a single patient, is strongly suggestive of a fungal disorder. So these patients, these non-invasive patients, do not require much of a surgical intervention, and no enter. So you can even do a, a limited chest surgery in this patient, or sinus surgery in patient, without giving them antifungal medications, which are obviously have some cytotoxic behavior also, and they are also hepatotoxic. So they are not only reserved for this invasive cases, and non-invasive cases usually don't require any of the antifungal agents. And this allergic fungal sinusitis, which is again a non-invasive sinusitis, this is typically it's a type 1 hypersensitivity reaction. In Coombs classification, we know four types of hypersensitivity. It is just like a IgE response of allergic rhinitis, like a mast cell mediators and eosinophilic response. And these patients always present with a polypoidal disorder. So nasal polyp is also always there, and this is supposed to be the IgE response or type 1 hypersensitivity reaction against a fungal element, fungal disorder, but never a invasive one. So this is typically a non-invasive pathology. And the thick eosinophilic mucin, which is very important, very important. These patients, what they are having is a like a charcoal leaden crystals of bronchial asthma. They are having a thick, tenacious, very thick eosinophilic mucin, which is a hallmark of non-invasive allergic fungal sinusitis. So the word is also very important. This is allergy against a fungal element, which leads to a inflammatory sequence. So it's like a allergic rhinitis type 1 uh, IgE mediated response against a fungal element. So atopy may be there. Atopy is a genetic behavior of a type 1 hypersensitivity, which is an umbrella term, and which has got three disorders like urticaria, allergic bronchial asthma, and allergic rhinitis. And these three terms are incorporated in atopy. So this is a typical non-invasive allergic fungal sinusitis. You can see multiple polyps are there. It's hard to determine even the structures which are present in the nasal cavity. So these typical presentation are seen in majority of this patient, and this is you can see there is a pushing of the bone is there, but there's no entrance of the fungal into the orbital cavity through the maxillary roof or the lamina papracia, and even the cribriform plate or the skull base is absolutely intact, which is and dual shadow is there. This is a whitish in between, like a pepper, salt and pepper appearance, I can say. And this is a much of a ventilated part of the maxillary sinus. So this dual shadow in a CT scan with the intact cribriform plate and lamina and maxillary wall is certainly suggestive of a non-fungal type of allergic fungal sinusitis. This is again a picture. This is a clinical picture, and this is a mucin. This is very very thick, tenacious, butter-like, peanut butter-like thing, which is nothing but a eosinophilic response against the fungal hyphae. Fungal hyphae. So this is again you can say a reliable indicator. So this is again a mucin, and the IgE count, because it's supposed to be a allergic response, the IgE count in allergic fungal sinusitis is always on the higher side, or on the there is a right shift in the case of a IgE in patients of allergic fungal sinusitis. So this is IgE level in case of a EFS is a strong indicator that the patient is having a allergic fungal sinusitis. The treatment in these cases is surgical debridement, or you can do a sinus surgery. Sinus surgery, you can open all of the opening of the different sinuses in the nasal cavity, widen them, and not necessarily peel off all the structures, because that will invariably lead to this scar formation and again loss of the mucociliary clearance mechanism. So aggressive surgery is not indicated, and the systemic steroids and topical nasal steroids, which are very very important, and the first line of a treatment in case of allergic fungal sinusitis. This has to be done for a longer period of time, along with the aggressive nasal saline douching or washing. Various equipments are also available in case of in order to deliver the nasal saline. So these are complications like orbital cellulitis, orbital abscess, and intracranial invasion, which can lead to like a proper pyogenic meningitis, a positive Kerning and Brudzinski sign, and neck rigidity, and high-grade fever, and photophobia, etc. And again, if the fungal element encroaches or gains entry into cavernous sinus, then it can also cause a cavernous sinus thrombosis. Thank you very much uh, for watching the video. You can also go on to the comment section if you have to ask any kind of questions about the video. Thank you for watching. Thank you very much.